Today, we have with us Dr. David Volders, who is a diagnostic and neurointerventional radiologist at UMIC.
The most important maneuver in neurointervention is just this small millimeter movements of the end of the wire where you can just deviate and how it goes in one direction or the other.
I guess this is the closest we have come to actually performing miracles. A person who has not been able to walk, and you're able to do something, and then he's able to walk.
You have no idea what you just witnessed. It's the coolest thing you will ever see in your whole career.
David, it's a pleasure to have you here.
Thank you for having me.
So my conception or misconception was that neuroradiologists, interventional neuroradiologists, are not seen anywhere else outside their own cath lab. That's the only place you see them. Because you don't get sleep, you don't eat anything, you just keep working because it's such an important job that you do. But let's kind of start from the beginning. One of the main things which you do, or the way I understand it, is to deal with stroke. Mm-hmm. But for the common public out there, what is stroke?
So there's basically two types of stroke.
Okay.
So you have the ischemic stroke, which is being caused by a blockage in a blood vessel. And then you have the hemorrhagic stroke, which is being caused by a rupture, either from an aneurysm or an arteriovenous malformation.
Okay.
I would say 80% of the strokes are being caused by a blockage in a blood vessel.
Okay.
The symptoms are often different. Like an ischemic stroke presents with people with weakness, difficulty speaking, that sorts of things. Well, a hemorrhagic stroke from a bleed presents more with a thunderclap headache. So the symptomology is different. The treatment approach is also very different itself.
Okay, so one is blockage and the other is leak of blood into the brain.
Exactly.
So do you deal with both or do you deal with one or the other?
Yeah, so we actually deal with both.
Okay, so you're the guy to see no matter what the type of stroke is. Okay.
Yeah, so on the one hand, one of our jobs is to open up blood vessels from blockage. On the other hand, we're trying to prevent rebleeding from these blood vessels that bled. So both approaches we do to a minimal invasive way. Mm-hmm. We're kind of like the plumbers in a way, where we go into the blood vessels or the pipes to fix them. But that's kind of our profession. And of course, these things present in a way you can't really predict, right? It's not an 8 to 5 job. So when somebody has a blockage in their blood vessel, it's not something you can say, let's wait until 8 a.m., until everyone is here, and now we're going to fix it. No, it really has to be dealt with in that moment, because it's very something acute that you can potentially still change the outcome.
It's interesting you call yourself a plumber, because it's kind of how it exactly is, right? Sometimes the pipes get blocked and sometimes they're just bursting all over the place and they have to come and fix it. And yeah, you're right. To a certain extent, like the plumber, you can have emergencies at any point of time. But I remember hearing something that strokes are incredibly common around the 2 to 4 a.m. mark. Is that true?
You're absolutely right. And we don't know exactly why. Okay. I think it's probably also because, when people are sleeping and it must have something to do with your blood pressure or just the state of your body which you're in. Mm-hmm. That, sometimes people have these strokes while they're sleeping and then, their partner wakes up. And it's hey, what's going on? And then they find their loved one having a stroke. So we call those wake-up strokes.
Oh, okay.
And one of the issues with those is that we don't know exactly when what we call the time of onset happens. As a interventionalist and also our colleagues from stroke neurology as well, they like to know when exactly did the stroke happen, so they can time their treatment. And
how is that important?
It's a good question. So there are two types of treatment that we offer to stroke patients. One of them has been done by stroke neurology. So if a patient presents within a 4.5 hour time window from their symptom onset, and there's no blood in the brain, and they still see there is no big infarct established yet, then they give a drug, a thrombolysis. And basically it's just an injection of a drug, goes into the veins, and then what it does, it can break up the clot.
Okay.
And that treatment in, let's say, 1 in 10 patients is effective. Now, if a patient wakes up, you don't know exactly when did that stroke happen, right? It could have happened an hour before, or it could have happened like just an hour after they went to bed. So any wake-up stroke is basically already excluded from that drug. And then you move on to the next treatment that we do. That's called endovascular thrombectomy, or EVT, where we basically go minimally invasive by doing a small puncture in the wrist or in the groin. And then we go up with plastic tubes called catheters, and we go through the neck, and from there we go into the brain and trying to remove the clot that is basically blocking the artery to restore the blood flow as quickly as possible.
Okay, so it's almost like you'd say a plumber using a snake to kind of clean the drain.
Yeah, exactly. And there's two ways of doing this. You can either use a stent, or we can also use what we call aspiration, where you almost suck out the clot.
So is it like with vacuum and stuff? And
Exactly. So it's literally like a pump. You hear like buzzing, and yeah, you basically pull the whole thing back and restore the flow. And I would say what we call a first pass effect, where you remove the clot in one go. It's about like 50 to 60% of the times that works. And then if you look at the total success rate, we're often like above 80 to 90% of restoring the normal blood flow.
okay.
So, and in terms of like how quick we can do this, because people think this is brain surgery, which it is, it actually goes relatively quick. I did a case last week with my fellow where basically from the puncture of the groin to opening up the blood vessel in the brain, we did it in less than 5 minutes.
Oh, wow. Okay.
That's exceptionally fast,
Yeah.
I must say. But like in general, most cases we can finish well within like half an hour. And that's important because, as you know, like time is brain. And, you know, like it's one of those things that once the patient has their stroke, we know that every minute the blockage is there, that you lose approximately 2 million brain cells. So
2 million brain cells.
2 million brain cells.
2 million neurons are lost every minute.
Exactly.
Oh, wow. Okay.
Exactly. So that's one of the things where, you know, people in stroke and in the guidelines too, that we really try to look for what are the different areas where we can really work on to improve those times, right? Our procedure, of course, is one aspect, but there is other aspects as well within the whole process of the of getting the patients from, you know, the moment they have their stroke to us on the table.
Interesting. So if a patient has a stroke at home, you first need to bring him into the hospital, and then, and again, it's not just any hospital, it's a hospital where you are available. And in the meanwhile, they need to get everything ready so that the patient can have imaging, I'm assuming, to confirm it is a stroke, because otherwise, how would you know? Like, you can examine the patient, but I still am assuming that you do need imaging as well.
Absolutely.
And then the whole thing has to be coordinated that you're available and the patient's on the table. So there's a lot of checkpoints between that, right? How does this entire process work?
So it's a good question. And I think this is also one of the misconceptions. You know, people think like stroke treatment, it's like kind of like, for example, an inflamed appendix is just a surgeon taking out the thing and you're cured, right? While stroke is actually a team-based approach. So like you mentioned, it starts with, you know, first off, you know, the loved one who actually recognizes the stroke.
Absolutely.
It's very important. And I want to talk to that on that like a little bit more, because we have actually found that if you look at a group of people and you ask them like, what are the symptoms of a heart attack? 90%, over 90% recognizes, chest pain. This is like very typical, right? People recognize it immediately on the street. You show people like, symptoms of a stroke. Only 1 in 3 people actually recognizes this.
Okay.
And this is a problem, right? Because symptoms of a stroke, they're often like either underestimated or ignored. There is this acronym called FAST, which stands for face, arm, speech, and time. And it's been put out by Heart and Stroke. You see it on all of the ambulances, actually.
Okay.
And basically what it does is it makes you think about those symptoms of a stroke. And you sometimes have a subtle facial droop or a little bit of arm weakness or like a garbled speech. So that people actually notify EMS and 911 and tell them like, I think my loved one is having a stroke. And then, they immediately prioritize that ambulance. When the ambulance gets there, they have different stroke skills that they can use to assess the patient. And there was actually an interesting study done from the Netherlands that compared the assessment by paramedics with the assessment done by physicians in the hospital. And they found that there is a very good correlation. So paramedics are actually very strong and good in picking up these subtle findings. Now, when that happens, then they basically notify their call center and tell them, listen, we have a patient with a presumable stroke. The call center then notifies the hospital that they know there's an ambulance that comes in with a patient that has potentially a stroke.
Okay.
And then you and I, like as radiologists, we get notified about this. The scanner is being put on hold. So the moment that patient that actually comes to the door doesn't need to wait to get priority imaging done, because that's also one of the things that we looked at the Canadian Stroke Best Practice Guidelines is you want to keep that door to CT time as short as possible, within 20 minutes. So you don't want to be waiting outside for a patient that's been just selectively scanned. So the patient immediately goes to CT. There is not much time for assessment by the neurologist. That often happens right after the scan.
Oh, interesting. So it's actually imaging first in the truest sense, that as the patient enters the hospital, gets a CT, and then the neurologist assesses.
Yeah. So and often it happens kind of in the breeze way. We don't really want to delay things too much.
Okay.
Right? Like you can literally within a minute, you can quickly do these things like show your teeth, raise your arms, raise your legs, repeat after me. Like in a minute, you can have an idea about, do I think this is a patient who's having a stroke, or is this nothing? So when the imaging is done, the patient gets like a non-contrast CT head, which is important to look for a bleed.
Yeah.
Like I mentioned before, that's important for the neurologist to know, can I give thrombolysis to this patient? A CTA is done. That's exactly to localize the occlusion level, and also for us to plan our procedure. Is the neck vessel, for example, blocked? Are there any other issues on the way? Is there maybe an aneurysm that is hiding somewhere, which will make things more complicated? And then the patient also gets a CT perfusion. And the CT perfusion is a very helpful tool because, for one, it really almost lights up the part of the brain that is being deprived of blood flow.
Okay.
So sometimes you might miss a small occlusion on a CTA, and then on a CT perfusion, there is this big color map that shows like, no, there is something there. And then you go back and you're like, oh, wait a second, there is indeed an occlusion. The second thing the CT perfusion does is that it shows the mismatch or match. And let me explain what I mean about that. So the CT perfusion, it basically can show you how much of the brain is already infarcted and how much of the brain is still salvageable. And the part of the brain that's still salvageable, we call that penumbra. So what the perfusion
just like
does,
the solar eclipse, just as completely dark as the umbra, that's probably dead, whereas the penumbra had received some light that you can still manage to salvage.
Exactly. So what we love to see is a very small core infarct or a small established infarct. and then a very large penumbra. That means there is still a lot of brain to save.
Oh, so to recap, so you're saying that every patient has all three done. That is, one is the non-contrast, that is before administration of contrast, to look if there's bleed. The second is an angio, in which primarily you're trying to look at the vessels. You inject contrast to pacify the vessels, you're looking at the vessels. And the third is a perfusion, in which at this point of time, you're just seeing what amount of brain tissue gets blood supply or not.
Yeah.
And all three are done at the same time with the patient on the scanner.
Yeah. And that's also something we advocated for in the Canadian Stroke Best Practice Guidelines. Obviously, not every center within Canada has perfusion imaging. It's more advanced imaging.
Okay.
But we did advocate for a thing called multi-phase CTA, which is basically a second and a third phase that you scan after the patient gets the dye injected for the visualization of the blood vessels. It gives us a little bit of an idea about the collaterals and how this patient is going to do. But in general, in our center and in I would say most of the centers where they perform EVT, you do have the perfusion as well.
Interesting. So two questions I have. One is that, does this additional imaging, I don't think that it's just a matter of time off imaging, but it's also all these images, right? Because any angio has these thousands of images. And then perfusion, I'm assuming it goes into a software, and then there are some recons performed, and then it's being pushed. Does that all delay things? And how do you kind of optimize that it's done as fast as possible? And also getting the right person there. You can't have a new resident there kind of taking care of it because it's more complex that way. Yeah. And how is that whole system set up that despite all this complexity, you're still able to give a very quick, fast answer?
Yeah, no, that's a very good question. So in general, so the imaging part, like it's gone up like in terms of like how fast it's been done. Like, you know, the scanner itself, it scans really fast. The bottleneck, like you mentioned, is a little bit the post-processing. But even now, I've noticed you get actually the imaging within a couple of minutes. And like I mentioned, stroke neurology, they still have to assess the patient. So you don't lose actually too much time in terms of your decision making. The perfusion imaging has been processed by a tool. There's several vendors on the market, but how it also works is, let's say if I'm, I don't know, grocery shopping, for example, right? I have an app on my phone that would notify me and say, hey, David, you know, there is a patient now in Toronto Western that's just been scanned. I detect that this patient has what we call a large vessel occlusion, which means that it's one of the main branches in the brain that's been blocked. And I see on the perfusion, this is the volume of brain tissue that there's still to save. So I immediately would get a notification. No matter where I am, I can be in Europe or whatever, I still get that notification. And it literally enables you to kind of already say, okay, I need to call my fellow, I need to call the team, I need to speak to anesthesia, like to get the ball rolling. So that's really been like a tremendous advancement actually in technology compared to, you know, let's say 10 years ago.
In which they probably had to page you and you had to return the page and then figure out what happened, and you hope you hear that tiny beeper going on.
Exactly.
Wow. David, the second question I had is that, if you remember, you were telling me that the first 4.5 hours, if there is a stroke, and it's an occlusive stroke and not a bleeding stroke, then the neurologist can just inject this thrombolytic agents. And at which point of time, I'm assuming that the location of the occlusion is not very important. So if the time period of the patient coming in is less than 4.5 hours, do you think that at that point you just do a non-contrast CT, see if it's a bleed or not, and then immediately start the injection? Or would you still want to do a CT, angio, and perfusion in those cases as well?
Yeah, no, that is an excellent question. And there are a lot of centers where they basically do that, where they say, you know, we do the non-con heads, you pause for, let's say, 2 minutes, the neurologist goes in the room and then checks the thrombolysis.
On the table?
On the table. Like,
wow, okay.
It's something, you know, like when we talk about the guidelines, everything is documented and every timestamp is documented. The moment that The patient gets to the door, that's timestamp 0. And then the clock starts ticking, and we know that we want to have a door to needle, what we call the needle of the thrombolysis, under 20 minutes. Now, you can understand, like, if, let's say, the patient gets first the CTA and then the CT perfusion, you add already probably easy 5 minutes to that time. In reality, I must say, like, it's a trade-off, right? Because in order for them to give the thrombolysis, they often need to know, like, what's the blood pressure? Are there any other contraindications? For example, if the patient is on a heart medication and is already taking blood thinners, they're not a candidate for that thrombolysis either. So neurologists are, in that sense, a little bit different than us interventionalists. We are more like go, 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 while they're more cautious, and they really want to rule out everything before they actually give the drug. But I've seen it happen where indeed, like, the patients, they pause for a sec, they give the thrombolysis, and then they continue. And those are the patients in general that, you'll love to see, that you can say, look, you did a door to needle within less than 20 minutes. Like, that's kind of like what motivates a team, so.
Amazing. So if the time period is more than 4.5 hours, I guess that's when you come into the picture to do it, or in cases in which the injection fails?
It's a good question. So we have actually seen that patients who get even both, let's say a patient gets thrombolysis, right? We don't wait to see what actually happens to the patient or the clot. Like, we actually just continue as if the patient didn't receive the drug. Like, I mentioned that the number needed to treat is 10, which is high, but at the same time, like, we actually know that EVT, or endovascular thrombectomy, is an even more effective treatment compared to thrombolysis.
So thrombolysis, you say that only 1 in 10 is effective?
Yeah.
Oh, wow. Okay. So 9 of them aren't completely effective. Only 1 is completely effective.
Yeah.
Okay. So that's kind of where you come in, because you make sure that at least in 80% of patients, it's completely clear.
Yeah.
Okay.
Yeah. So, but like that's talking about the effect. I mean, the opening up the blood vessel. It doesn't necessarily always correlate with the outcomes, right? Like, sometimes we go in knowing that, there is already a significant part of the brain that's been infarcted, but we still want to give the patient a chance, and we think like there's still some salvageable brain. Like, we know from our data that, especially with the initial stroke trials that were published, that for every, let's say, 2 to 3 patients you treat, you make 1 significantly better. Now, you think to yourself, is that a high number? Like, that sounds like 1 in 3. That's not that much. But if you compare it, for example, with giving antibiotics to a patient with sepsis in an ICU, that's only an effect of 1 in 7. So actually, EVT, or endovascular thrombectomy, is actually, and rightfully so, they say, one of the most successful treatments in modern medicine in terms of, like, the procedure you do and the outcome that you can get. And that's always the way I describe it to the family as well when I do the consent. Obviously, I need to mention there is a risk I cause a complication. I can damage a vessel going up there. I can cause a bleed. However, that risk versus the benefit that the patient has, it's definitely like, it definitely outweighs it. And I've not known like one family that said, no, I don't want to take the risk. Like, it's basically we help this patient, and there is a chance we can get them back to the way they were, their complete baseline. Or you're just accepting, you don't do anything, and then they basically end up with a very, very, very bad disability. So
Interesting. So at that time point, when the patient's being imaged, you also have to speak to the family and keep them updated with what's going on, because you want to get things fast for the patient, but the family are really worried. Like, we can't make decisions on their behalf. So it's a very tricky situation in which, while everything is being done and set up, you always also have to deal with the family, keep them updated, and educate them, and tell them what is going to happen as well.
Yeah,
that part of it, I had never thought about it. But once the imaging is done, Is it the same that similarly you keep your angio suites open and waiting for the patient? Because, there can always be other procedures which are happening, which might take a long time.
Yeah.
So somehow you need to find a way to get that in as well, right?
I think like as an interventionalist, and it's an excellent question, that's the most probably sometimes stressful part, where we do have a big center, we do have more than one room, but on occasion, for example, there's one room that are doing maintenance. There is another room where a patient is asleep and they're doing a procedure. So how do you work around that, right? And then, of course, there is a difference between day and nighttime. Like I've had more than one occasion where, you're treating someone and then all of a sudden there is a neurologist who comes knocking on the door and says like, I have another patient in Emerge that has a stroke. So, you really have to know that they can come at any time. They can come multiple sometimes at the same time. And you kind of have to sometimes be flexible and find ways to work around it. I used to work in Halifax, and I still remember up to today, there was this one occasion where we had a patient with an occlusion, and they had a case going on in the main neuro room, and they also had a case and a patient who was asleep, a big case in the other room. So there was like nowhere to go. So I was like, okay, what would I do if I was an interventionalist, let's say in a second or third world country? So I called my colleague from vascular surgery, and this is something we would never do. And I said, do you guys have a C-arm or something I can use to treat this patient? And he's like, oh, you know what? We just finished the case. Just bring this patient up. And, you could say, well, you could wait and do it with the fancy cameras and everything, and that would work well. And I was like, you know what? Like, I don't want to delay care for this patient. Let's go up to the OR. And, we brought all of our equipment, our catheters, our pump and everything, got the patient on there. And it was literally, I had to tell them to kind of move the C-arm with me while I was going up. I had like just a crappy little almost screen compared to this huge screen that I normally use. But I was lucky. It was a very quick case. And I still remember the vascular surgeon standing behind me, and I heard him talk to the medical student. And he literally said, you have no idea what you just witnessed. It's the coolest thing you will ever see in your whole career. There is nothing cooler and more impactful than this. And the patient literally improved on the table. It was like, yeah, those kind of cases, that's like the best feeling in the world. Like,
I have goosebumps, literally. Because I don't think people really understand the difference. A C-arm is one of the most basic fluoro machines which were ever invented. And I think that everything was built on top of it. But now the level of sophistication is so different. It's as different as having a flip phone versus a recent iPhone. And let's say that you had to connect to the internet and look at something. The difference is massive, especially when you have to do a procedure of that complexity.
Yeah.
That's insane. I am super impressed with that.
Well, I must say, like afterwards, like I really had to go outside and kind of like, what the hell did I just do here? But like it was literally you with your back against the wall, right? Yeah. Like, and that's the kind of thing. It's not only logistically, you kind of learn that in our type of field too, that you have to learn to pivot. Like you can be doing the perfect case and something might go different, and you need to have a plan B, a plan C. And that's the kind of thing like what makes our specialty so interesting, right? Like it's never predictable. It can happen at any moment of the day, and you just have to sometimes improvise. So
one additional thing I wanted to ask is that when you get these catheters in, there's no way of driving the catheter, right? It's just a tube. So you still have to somehow find a way to go into that tiny vessel in the periphery. And in addition to this, what are the other technical challenges which are there in terms of the procedure itself?
So it's a good question. So anytime we bring up like that plastic tube, like you mentioned, we always guide it over a wire. So and the way it's not just a straight wire, we basically use a little bit of a curve on the wire. And what we do is by just very fine manipulation outside, we can make that wire kind of like the angle flip one
Just
way or
change
the
one
other.
way. Okay.
And it's kind of like you can deviate it so you can know the direction where it will go.
Just with that.
Just
right?
with that. And this is like one of my mentors in Montreal that trained me, Dr. Jean Raymond. He always told me, he said, like, the most important maneuver in neurointervention is just this, like, small millimeter movements of the end of the wire where you can just deviate and how it goes in one direction or the other. So one of the things and challenges that we face, especially also with stroke patients, is that these are in general not always the most healthy patients, right? Occasionally we actually have young patients as well that present. Often the cause is then from the heart, right? But more often than not, we have older patients, smokers, patients who have high blood pressure, high cholesterol. And one of the things that happens in those scenarios is that with hypertension, your vessels kind of start to get more loopy.
Okay.
And with every loop you take, it gets more difficult to get your catheter all the way to the top because you're building up tension. So that's one challenge. The other challenge is with all that unhealthy lifestyle is that your neck arteries start to slip up. And sometimes you have a thing called a tandem occlusion where you have an occlusion in your brain, but your neck vessel is blocked as well. So the road to get up there is blocked. So you basically have to deal with two problems instead of one. And that makes it, of course, more challenging. I'm not saying impossible, a little bit more challenging. But yeah, we deal with that as well. So those are all kind of things on imaging, where imaging is such an important aspect to kind of plan that out in terms of like, you know, the material you want to use. Do I want to ask anesthesia, for example, to put this patient to sleep? Because I think this is going to be a complicated case. What do I tell the family about, like, you know, how does it look? So imaging itself is a very important thing in this whole picture.
So yeah, so when you initially said that you did a case in 5 minutes, it's not because it's easy. It's just because that you're so damn good that you were able to do it with the C-arm that you were finally able to do it.
Well, I'll be honest, the fellow did the whole case.
Okay.
It was all credits to the fellow, but like that's also part of my job to train and trust them and help them plan as well, right? Like so. But
we don't need more people, more fellows and trainees all over, because the way I think about this is that one of the most crucial things is getting patients on the table. You're in Toronto Western, and people in Toronto are lucky. But what if they're like one of these smaller northern communities? So we need this setup in most places because travel is going to be a bigger issue, right?
Yeah.
So what are the biggest challenges in the rural area if somebody has stroke? In addition to the, you alluded that the patients near and dear ones have trouble identifying it. But even if they did, what are the other challenges they face?
yeah, transportation, of course, is a big issue, right? I'm originally from Belgium. I worked in the Netherlands as well. You literally have a EVT or a thrombectomy center every 20 kilometers. So it's
wow,
like there is no issues like that. Well, in Canada, of course, you basically have to like account for that transportation time. Now, we're fortunate that we do have a good EMS system where, you know, sometimes patients are being flown in, you know, with priority or been driven in with priority. But even then, and I mentioned this about the Canadian Stroke Best Practice Guidelines, where we really want to get proper imaging in terms of like, what do we think the collaterals are? Do we think there is do we think this patient is going to progress fast, or do we think this patient is going to be a slow progressor? And let me explain about that. Like every stroke is different. So you do have some blood vessels that help out in case you have a blockage. And some patients have really excellent blood vessels. So they can actually last up to over 12 hours to even 24 hours and still open it up and have a good outcome. While there are patients who have very poor collaterals or poor blood vessels that help out, and they basically can have a stroke, a blockage, and within a couple of hours, their brain is already completely gone. So having that information is very important. I know there is some talk about, I mean, maybe even in the future, having robotics where I could perform the procedure from my center. We have a robot remotely that can do this procedure for me. That would be one avenue. I know in Saskatchewan, they actually have an interventionalist that goes in a helicopter and sometimes flies over to the center themselves to do the procedure, because that would be faster than bringing the patient over.
Okay.
So there are ways that we try to make things better. I think the guidelines are important, but it is definitely a big issue. I'm not going to deny that. Yeah.
Interesting. So I guess hopefully one day we have all these like Optimus robots everywhere and the patient can be done. But till that day is achieved, what do you think is the interim solution? Training more people and having more specialized centers across Canada? Or do you think AI is going to somehow help in this whole thing?
So it's a good question. I think at this moment we just need more centers that do endovascular thrombectomy, right? I think AI is promising. At the moment, AI itself, its performance, like we spoke about, is particularly good in imaging. But even there, you get a lot of false positives, also false negatives as well. And, we still need radiologists to interpret the imaging. Now, in terms of like the AI in the field, like I mentioned, we don't really have the data around that yet. We don't really know how well is it going to perform. And the thing with AI is that it is very much, it works different in different work environments. For example, an AI system that's been trained, let's say, in the GTA, it's going to pick up things different than, let's say, if you're somewhere, all in a rural area, because it's a whole different environment, right? Then you have stroke mimics. Then you have like a different, let's say, different type of population. So for AI to pick up on those differences, it's hard. Like it's already very difficult to pick up in a perfect scenario. The last thing we want is to tell AI, oh, can you tell me if this is a stroke or not? Like I personally would not feel comfortable with that, because the stakes at this moment are so high that, like if they miss it, then that's the end, right? Like that's no treatment for that patient, and then the outcome is like gonna be detrimental. So do I think it has a role in the future? Absolutely. But in order to do that, we need really randomized controlled trials. We need to run those. And then if that shows there's a clear benefit, then we can pour that into the guidelines. But at the moment, I think we're definitely far from there. Training more people. It's a procedure. You don't necessarily need to be a neurointerventionalist for it. Like even body IR people do these procedures as well in some centers.
Interesting.
So it's a technically challenging procedure, but the material got better. The imaging got better. So it's become more and more easy, I would say, to perform this procedure, which is in a way great, because you do want people to do these procedures in order to improve the outcome.
But if you have more people doing the procedure, you're probably not doing it as often, right? Is there a critical number you need to be doing to keep up your skills, or that doesn't really matter here?
No, it's a good question. There actually has been people who looked at this, and yes, like the number, you need to do approximately 15 of these a year to kind of keep your skills up. They say if you do less, then you actually cause more harm to the patient.
There you go.
But there is definitely something to say about having experience, but it's all a trade-off, right? Like I said, like within Canada, the situation is very different than, let's say, Belgium or the Netherlands. I think like it's good that we do have people in the rural areas that are doing these procedures. Do they have as much experience? Not always, but like the trade-off between transferring the patients for like 4 or 5 hours over to another center versus them doing the procedure, it's a very delicate and complicated question to answer.
So I guess your advice is for more trainees to be trained and more people to be doing it all over. So in that sense, what would your advice be for trainees? Especially because back in the day when we lived in the era of barium enemas and swallow studies, radiology was considered a lifestyle specialty. Even on the diagnostic side, it's not that anymore. The number of hours most radiologists put in are much more than most clinical specialties even. But you live on the other end of that spectrum, in which you can be called at any time and you always have to be there. There is a lot of pressure, and you've been doing amazing with what little you have and all the issues which kind of crop up with it as well. So what kind of trainees are right for this type of job? And for anybody who is interested in doing it, what advice would you give?
So first of all, like, I think if you have like any interest in neurointervention or intervention in general, come spend some time in the Angel Suite and come see what it is. Like when I was a resident, it was almost like a holy place, you know, like a lot of people speak about it. It's like, you know, you kind of really don't know exactly what's going on, but it to me, like, it really has something magical. And then I think it's also important to know, like, if you really somebody who likes working in a team, who likes working with people, like our profession, it's really like a team sport. Like my job personally, everyone's like, wow, you pulled out that clot, let's say in 5 minutes. Yes, but at the same time, like, it's the EMS that brought the patient in as quickly as they could. It's our radiologist who recognized the diagnosis, or the CT tech that got the patient quickly on the table and took the imaging. And, you know, there's so many different people who are there in that process that makes it like, you know, a team sport. So if you're somebody that really enjoys working together with people, then this is really something that is for you. And I think also the high stakes, but also very high reward.
Exactly. Yeah.
That itself, where you are the one that makes an impact. If, let's say, this patient can walk out of the hospital from being completely hemiplegic to being completely back to normal, like, you know that you don't only made an impact on the life of that patient, but you made an impact probably more than 15 people around that patient who would have otherwise had to change their whole lives, their whole careers, because it would mean that you have to take care of your loved one for the rest of your life. And that's like, you're not just treating one patient, but the impact around it, it's so important. So for me, like, it's one of the reasons why I love doing neurointervention, for that reason, because it's just so exciting, and it's really like a passion of mine. And like, just to tell the vascular surgeon, like, yeah, it's one of the coolest things you see when you're treating a patient who is completely hemiplegic, and you pull out that clot, and like minutes later on the table, all of a sudden start talking to you, and they raise their arm. It's incredible. Like, and also our colleagues from anesthesia, each time they get excited about this too, because like, yeah, that's what keeps the team going. If it's like, you know, 8 a.m. or it's in the middle of the night, that's the thing that really gets you out of bed to do these procedures.
That's incredible hearing from it. I don't want to be blasphemous, but I guess this is the closest we have come to actually performing miracles. A person who has not been able to walk, and you're able to do something, and then he's able to walk. So that's a great pitch. So for any of you hearing out there, if you want to work miracles, if you want to be incredibly satisfied that you're helping patients and the families around them, yeah, you should strongly consider a career in neurointerventional radiology. David, it was a pleasure having you.
Thank you for having me.
Thank you very much. And hope to see you in the NeuroAngio Suite soon.
Always welcome.
Thank you.
Thank you.